This podcast is not CME eligible. If people do want to learn more about CME eligible podcasts, Alex, what do they do?
They can go to GeriPal.org/CME.
And on to the show. Welcome to the GeriPal Podcast. This is Eric Wadera.
This is Alex Smith.
And Alex, we're going to be talking about deprescribing at the end of life. Who do we have with us to talk about this?
Today we have two guests joining us from Europe. We have Jen Tjia, who is a geriatrician and palliative care doc and researcher who's at UMass Medical Center, but is currently on a Fulbright scholarship in the Netherlands at Leiden University Medical Center. Jen, welcome to the GeriPal Podcast.
Thanks for having me here.
And we're also delighted to welcome Simon Mooijaart, who's an internist geriatrician and chair of Geriatrics and Gerontology at Leiden University in the Netherlands. Simon, welcome to GeriPal.
Thanks for having me.
And delighted to welcome Jon Furuno, who's an epidemiologist who studies hospice and palliative care and is at Oregon State University. JJ, welcome to GeriPal.
Good to be here.
While I love Oregon, I got to say, I visited Leiden a year ago, and I thought it was one of the prettiest cities I've ever seen in my life. Yeah,
100%. Can't go wrong.
If our listeners never visited Leiden, go visit Leiden. It is amazing.
I'm completely biased, but I agree with you.
You're going to have a flood of GeriPal podcast listeners coming your way.
Okay, but we're not talking about Leiden. We're going to talk about end of life deprescribing. But before we do, we always ask for a song request. Who has a song request for Alex?
I believe that's coming from me.
JJ,
Yeah.
What'd you pick?
I picked Broke Down Palace by the Grateful Dead.
Why did you pick this song?
It's a beautiful song. I think, the Dead just lost another original member in Bob Weir not that long ago. So it's been on my mind. I think there's different interpretations of the song, but it gets played a lot at memorial ceremonies. And I think it's just a really beautiful, beautiful piece. I think it'll kick us off well.
Last question.
Yeah.
Are you a Deadhead?
Yes.
All
Admitted.
right.
Have you been to a concert?
I never saw the original Dead. I did see the other ones and some other side projects.
My first concert was Grateful Dead, 8th grade in Ann Arbor. Amazing show.
There you go.
The Bob Weir, who just died, was a resident in Mill Valley, which is where I'm recording this podcast right now. And as was Jerry Garcia and Phil Lesh, they all lived in this area. So sad talking to people like Lynn Flint, who's been on our podcast frequently, who saw Bobby Weir around town. So, yes, a very appropriate song. Thank you for choosing this one, JJ. Here's a little bit. Fare you well, my honey. Fare you well, my only true one. All the birds that were singing are flown, except you alone. Gonna leave this broke down palace on my hands and my knees. I will roll, roll, roll. Make myself a bed by the waterside. In my time, I will roll, roll, roll. In a bed by the waterside, I will lay my head. Listen to the river sing sweet songs to rock my soul.
I can always tell how much Alex likes a song, depending on how long the intro song goes. He likes that song.
Great. It's great.
All right, I'm going to start off with a big question because all of you have focused a lot of energy and interest and academic rigor on this topic of deprescribing at the end of life. Why? Like, what got you interested in this? Jen?
The story is, when I was a geriatrics fellow at Penn, I got to live around the corner from my partner's very world-famous violin teacher who was dying of cancer. And we got to take care of him and help him manage his meds and see how his family was dealing with all these meds that he was taking. And long story short is that the family was so stressed out about trying to figure out which meds he should take, how to get all of them into him at exactly the right time, say TID or Q8 hours. And they couldn't tell. They just freaked out every time there was some sort of dose that got missed or something. And I knew as a clinician which ones were important or not, but they were equally stressed out about anything that was not right. I was like, we got to do something about this and make it simple because there's all these unintended consequences.
Yeah. Oh, yeah. And the geriatrician probably in you loves medication debridement. Like,
well, yeah, and it was just like one of those things. This was a long time ago. We won't talk about how long ago it was, but this is before we started talking about less is more. And, we got to do less because this is, not all these things are necessary. And it's maybe not helping.
Yeah.
But that's why I do it.
Simon, how about you?
Yeah, so I think my interest also comes from just my clinic. And every time that you want to stop a medication, I notice how much harder it is to stop than to actually continue or even start something. And then you see patients dying with still taking all kinds of medication until the last day of life. That's intriguing and also a puzzle and also very hard just to deliver good care, I think. So that's where my ideas come from of trying to solve something in that.
Yeah. Do you have like a top three most like, why are we doing this at the end of life drug?
Well, one that I am currently studying is about antithrombotic medication. But I previously also did a lot of work on thyroid medication in people with subclinical hypothyroidism. And we found across all kinds of trials that it's not very helpful to take the medication. But now around the world, millions and millions of people are on thyroid medication without actually any benefit of it. How are we going to stop all of them taking it? So that's also one that is in my top.
God, I'm
top
really
list.
interested in hearing about that. Jen, did you have a top three?
Statins are definitely up there. And these antithrombotics are hard because so many people have atrial fibrillation at end of life. And I've done work on anti-dementia meds, but that's so controversial. We might not want to go there, but it's been studied a lot.
Wait, are you saying it's controversial?
No, there's no controversy.
Not controversial. Not controversial.
No,
well, let's go there anyways. We'll start off with the easy
you like
ones.
controversy? Okay.
No, we'll do both. JJ, what's your origin story in all of this?
So I'm not a clinician. I trained as an infectious disease epidemiologist at the University of Maryland. And one of the areas I was working in was antimicrobial stewardship in nursing homes. And I think thinking about what other care settings and populations where there's probably a lot of antibiotic use, but not a lot of evidence to support that. And hospice and palliative care did come to mind. Did some lit searches, and I was correct in my assertion. So our first paper, we leveraged the NHHCS data, so the National Hospice and Home Care or Home and Hospice Care data that are no longer collected, but to look at antibiotic use, and saw that about 20 some odd percent of people were still getting antibiotics in the last week of life. Published that in JPSM. So we've published a lot on that topic. It's very hard. I think I'm not a clinician, but my top three antibiotics would still be in my top three as one where I think we still struggle with. And speaking with clinicians, we still struggle in nursing homes. And I think the evidence is still lacking to support those decision making.
Anything else that would pop up in your top three in addition to the antibiotics? Easy or hard?
I think, which I think triggered me being here is are also working a lot in the antithrombotic space and with Jen and with our team here. And we have doing a lot of similar work to what Simon, I know, is done in the Serenity group. So I think those meds certainly are definitely in my top three. And statins, the other part of my origin story, I guess I should mention, is that when I talked about this and I went to my first PCRC meeting, I'm not sure when that was, people said, "Oh, you really need to go talk to Jen Tjia." And I don't think that they knew that Jen and I would become like very, very close friends. And I think we would, everything else that came with that. But, my favorite research collaborator and wonderful person. And I think we've learned so much from each other. So So statins, I think, are on the list, and that was the first paper that Jen and I did together. So that's still up there as well.
Well, statins is the one with the, we really have, Gene Kuttner and all those folks put out the statin deprescribing trial, the big one for hospice eligible patients, where we show that, or they showed that you really can stop them and that, you possibly can improve quality of life, which I think all of us as geriatricians or clinicians are really concerned about, right? So statins are a big one.
So statins, I'm going to start off with statins. So we do have one randomized control trial, right? Deprescribing, Gene Kuttner, that showed really no difference. But I think the controversy of that one was it powered well enough to show a difference between the two groups?
Well, I think the issue there was that I think it was meant to be powered to show no difference, and that, all trials, and Simon will talk about this, are hard to do. And trials at the end of life and in hospice are super hard to do. So Gene and her group did a heroic job. And they got as many people as they could. And that's the controversy. It was, they probably needed more to show 100% no difference, but they got pretty far.
Well, I'm going to jump to that question. Simon, why is it hard to do this at the end of life? A trial's a trial.
So doing clinical trials is hard anyway, because all of the regulatory issues, and if you're looking at particular patient groups that are quite small, then you need to do it in a multi-center way, and maybe in Europe even in a multi-country way. So that is already very complex. And then one of the things that is very hard to do in the first place, if you are doing a trial like that, is establishing what are we actually studying? What should be the primary endpoint? So in oncology, they just take something that is very easy to measure, something like mortality or so. But that's not what we are interested in. We are interested in quality of life. But how do you measure quality of life? And how do you measure quality of life in people who die very soon? Is it then quality of dying? Well, that's just one of the aspects that we in trials have always struggled with making that very solid. And luckily, it's being more and more accepted that these are the endpoints that we are actually interested in. But it makes it harder, because you need to measure quality of life in people who are dying. So somewhere 3 days before they die, you're going to call them and ask them, so by the way, what's your quality? So that's really hard. But it is the way to go, I think. And well, that's interesting to see how that field is evolving over time, and how there's coming more and more attention for this important part of life.
So maybe we could just start off with some of the easy meds to deprescribe, or debridement of medications at the end of life. It seems like statins, it would be a rare occasion where you'd want to continue a statin or recommend continuing a statin. Would we all agree with that?
Yeah.
I think so.
Yeah. Jen, I got to ask you, dementia meds. You mentioned dementia meds. Are they controversial or not? Deprescribing at the end of life.
I think they're hard, because everyone's afraid that a lot of people have clinical experience or personal experience seeing that if we stop the meds, well, people are always worried that things are going to get worse, right?
But would they have gotten worse anyway?
Exactly, right?
And they barely worked to begin with.
Well, I wasn't going to say it, but you said it, because I work with a lot of believers. And I've worked with a lot of believers who wanted to say, well, the geriatricians and the nursing home docs just don't know how to prescribe the dementia meds. And I'm like, no, they don't work anyways. But you said it, so thank you, Eric.
Yeah. It's hard to imagine a drug that barely works to start off with, that all of a sudden, people get much worse when you stop it, especially if you titrate it down.
Yeah.
So dementia meds, I think I agree. Like, we have no evidence that people with advanced dementia benefit at all. Like, zero evidence that they benefit. All the studies are like mild, moderate, severe dementia, but not end stage, not end of life dementia. Now, I can imagine if you have somebody with like moderate dementia who's dying from pancreatic cancer, maybe in that situation, right? But even there, like, you have to think about the risk benefit, especially around nausea, decreased appetite, syncope, with all these meds.
100%. They're not eating anyways, right? They're not eating anyways. They're probably taking 10 meds. Like, let's let them eat real food as opposed to, the 10 meds that might not, or at least the dementia med that might not be helping them, right?
Any other easy call medications, like ones that are not kind of controversial? I'm going to throw dementia meds in there. Alex, you got any for you?
Well, we have talked about in this podcast lag time to benefit for some medications like osteoporosis meds, bisphosphonates, for example. The lag time to benefit for those is probably a year, which is pretty short. But if we define the end of life time period as being much shorter than that, 6 months, weeks, months, the average length of stay.
But that
in
also
hospice.
raises another interesting question, which makes it hard as a subject. That is, how do we determine end of life? How do we know that this is going to be the last year or the last 6 months or the last 3 months?
Right. It's easier as a researcher to do a retrospective study and start at death and look backwards. It's a lot harder if you're trying to do a prospective trial and you want to identify people who are within X time frame of dying. So you need to look at people who have a short prognosis. And as somebody who studies prognosis, we know that it's really hard to do that. So we do the best we can. Others that we've talked about on this podcast include medications for tight blood sugar control. We don't need to be doing that when the lag time to benefit for tight blood sugar control is on the order of, 8 to 10 years to prevent microvascular complications, right? Retinopathy, nephropathy. We've talked about tight controlled blood pressure as well as not being as important, and we can start relaxing some of those meds.
Yeah. I think that has come a little bit under debate after the Danton trial, right?
Tell me about that one. What's that trial?
Please.
So we did a trial in nursing home patients with dementia. So that's a very frail patient population who had neuropsychiatric symptoms. And then we did a randomized trial, and in one arm tapered down the antihypertensive medication with the idea that would increase their blood pressure, that would increase their blood flow in their brain and would decrease their neuropsychiatric symptoms. And the trial eventually was stopped prematurely because of more mortality in the intervention arm. So there was more mortality and more falls and more heart failure in patients in whom the antihypertensives were tapered down compared to those who remained on the same level.
We're doing a podcast about this one. This was the study published in New England Journal, I believe. Is this nursing home residents with dementia? First author's name is Athen.
Yeah, that's the one by Anastase Benetos, and the one I'm talking about is the one that is that's been published in Age and Aging, the Danton trial.
Okay, all right. So different trials. All right, we'll have to get links to these and put them in the show notes. This is great. Eric, I know you have a favorite related to BPH.
Oh yeah, finasteride for BPH, benign prostatic hypertension. Like it takes 6 months to work. It's going to take at least 6 months not to work. Like it decreases.
Yeah, well, that's a good one.
Yeah. Calcium, vitamin D. Like, man, the amount of times I just click, stop it.
Yeah, vitamins.
Yeah.
Should we be giving vitamin D anyway in anybody who doesn't have osteoporosis?
It's a good one just to stop. Anything else that's coming to your mind as far as easy ones?
We should do that.
Easy ones that are non-controversial.
I would argue that there's not very little evidence to support I'm playing to my strengths here about antibiotic use. I think that there's few good indications for why this would continue after hospice admission, in my opinion.
Symptomatic UTI?
I just wonder if you can palliate. What are the symptoms that I guess you're referring to? Suprapubic pain? Yeah, sure. Can we palliate? Can we do something?
I think most commonly, JJ, it's somebody with confusion. They get a culture. It's positive because it's going to be positive anyways.
Okay.
Yeah, they're all going to be back.
Fair point.
Most patients will be bacteriuric. Are they actually symptomatic? So are we treating asymptomatic bacteria and things like that? So,
how about suspicion of pneumonia?
Right.
Yeah, right.
All right, let's talk about antibiotics. Because I think there's ones that are easy.
This, right? Like this happens.
There's ones that are easy for me. Statins, vitamins, finasteride. Like I'm just stopping things left and right there. There's ones that are middle ground for me, like antibiotics. Like I remember, I think it's JAMA IM. They did a retrospective study looking at antibiotics in people with advanced dementia, looking at comfort, mortality. And what I remember from that study is antibiotics in people with advanced dementia do appear to prolong life, retrospective, so all these confounders, but don't improve comfort, quality of life. And there was no difference between sending somebody to the hospital versus doing antibiotics in the nursing home, and no difference between IV and PO as far as the mortality benefit. Knowing that, again, there's tons of confounders. Like the people who are being started on antibiotics are different than those who are not.
Mm-hmm.
Thoughts on that, JJ? Like what is the evidence that you've seen around antibiotics? Let's say in particular, around dementia, and do you trust that data that's out there?
Well, I'm biased in that paper because I know the authors very well.
I thought you were going to say because I was one of the authors. Oh my God.
Well, 1 degree of separation. So I think those data are good. And I think that was a very nice study. I don't, but I just feel like in general, there's just not good indications, and especially in hospice admission for the biggest indication is that it's a barrier to people entering hospice. It's like they won't go unless they can finish their course, or that they know that they'll be able to, if they develop a UTI, that we'll treat it. You know what I mean? But do they really want to hear about what C. diff infections look like, and people that are and most people have just this presumption that antibiotics are benign and they can only help. I mean, I think we don't talk as much about the side effects. I think the side effects for antithrombotics, I think, are better understood. The bleeding risks and things, and I just don't think that there's good data and to continue. And I wonder if there ever will be. I mean, I just worry about how. We've tried to get those types of projects funded. I think they're really hard. I'd be very happy to.
What would that study look like, JJ? If I had a, unlimited sum of money, and you're going to try to, I'm willing to fund any study you want, JJ, around antibiotics at the end of life.
God, I'd have to think about it. I mean, I think a lot of these things, as we indicated when we talked about, for a lot of these studies, we leverage electronic health record data, or, we try to but we know that this isn't just very well documented in the symptoms. We don't know if people actually, diagnosing a true infection, and this patient population, I think would be tricky. It's not just infection. So I think a prospective cohort study is probably the way you would go with this, and then our trial. I think
I think they have had a prospective cohort study that followed that paper that Eric was talking about. I think Susan Mitchell did it in advanced dementia. I don't remember. I think it was called SPREAD.
I think so.
The acronym. I don't remember the results. But I'm curious if, Simon, can we do a randomized controlled trial of antibiotics at the end of life, or is that just way too hard?
Sure, everything is possible. It depends on how close to end of life you want to go. So, yeah. So I was thinking also about this. If you consider end of life really the last days of life. So in one paper I read that if you are admitted to hospice, that then the average time before you die is only 9 days. So that's really the last week of life. And I think there you would do a completely different trial than you would say 3 months before end of life or something, or if you enter the palliative phase.
Mm-hmm. Yeah. So on hospice enrollment is one marker that you could use in a study.
Mm-hmm.
Prognosis is another. I've had several cases in clinical work where patients who have like widespread infections, like infected hardware, something like this, and they're on IV antibiotics, and it's just things are going miserably, and they decide to focus on comfort, and we transition them into our hospice unit. And then we go to the ID consultants and we say, hey, we need to take them off of IV antibiotics and put them on something oral for the remainder of their lives. And their heads explode and they say, there's no data around any of this. What are you doing? In those sort of cases, it does seem like it's prolonging life and quality of life by suppressing that, level of infection. So that is kind of like one of the exceptions. And at some point, it won't make sense to continue them.
But JJ, I got to ask you this: I think there's probably, again, like treating pneumonias with like oral antibiotics in a nursing home may prolong people's life for pneumonia. Again, UTIs, I think that one study you mentioned showed no benefit, because most of the time for UTIs, it's actually quote unquote it's just, asymptomatic bacteria that we're seeing. But I can make a case that there's a mortality benefit. It may prolong life. I don't know of any data that improves quality of life or improves comfort. Like, all the data I see is it probably doesn't. Like, we have a lot of other ways to do that. Would you agree with that?
I would agree with that. I've also heard kind of cases where people will treat their pneumonia, they'll actually get better, and they'll actually get, booted from hospice because now, and it becomes this horrible cycle. So I think it can be really tricky as well. I'm worried that it's not helping people is like kind of the short answer. And, there may be some short-term benefits. The suppression I get, and I know that is the clinical justification, is that it's sometimes that it's suppressing this infection, which could be causing discomfort. I agree that that's probably happening. I mean, again, as a non-clinician, but generally speaking, and I think there's going to be individual cases, but I don't think the evidence is there to justify the magnitude of use. And as Simon said, especially as when you're getting into like the last week of life where we've seen it. So,
and my experience, it certainly in that period does not improve comfort. Like, there's so many other ways we can help with comfort. Jen, would you agree with that?
Oh, there's tons of ways we can help with comfort. Yeah, but one question, as we're having this conversation, I wonder about like who we're treating. Like we obviously think we're treating the patient, but there's a lot of issues of family concern. Families feel like that we should be doing something, or sometimes families have guilt. Like, when you're stopping all these meds, what do your patients and families say, Eric, or anybody else?
That's very recognizable in the clinic, that you have a patient and a family that all of a sudden they become aware. Okay, so now you're entering the phase of dying, and usually that is a huge shock, and I think it's very defendable to take a step down approach there, where you say, okay, well, the first step is that either way, whatever happens, we are not going to send you to the ICU anymore, and we are going to try to get you to hospice, but we will continue antibiotics to keep it stable. And then after a couple of days or after the transition somewhere else, then you can say, well, let's now also stop. Doing all of that together is usually, in my experience, it's just too much for patients and their families.
Yeah. I do think that there are ones that are easy, where there's usually and I can just lump them when I'm talking to families. I think we're going to stop all the medicines that we don't think are going to help anymore, including X, Y, and Z. And there's no pushback. I'm not consenting. It's just an assent. There's ones that I think I struggle with that are harder. I think antibiotics, like we talked about. Simon, I'd love your thoughts on thyroid meds that they've been taking for years and years and years. Diabetes meds, thyroid meds. Those I think people struggle with, especially if there's potentially a symptomatic benefit like thyroid meds.
Yeah, so for thyroid
there's
meds,
ones that I think I struggle with, but family members struggle less with, like anticoagulants, because it's going through my head, but I don't think it's quite like they're not as well attached to it. Simon, what do you think?
Well, so I think for thyroid medication, so a lot of people are taking them for subclinical hypothyroidism that was established 20 years ago, and they've been on it ever since. And then on a low dose, so probably everything up to 75 or 100 micrograms, you can just stop it. So I wouldn't be very hesitant about it. In my opinion, everything that is cardiovascular is very, very hard for patients and their families to stop, because their cardiologist, I'm going to say this a little bit blunt, but their cardiologists have been saying for 20 years that if you don't take it, you die. So that's where I always notice that if you start talking about stopping anticoagulation medicine, that people then say, no, but my cardiologist says, okay. And then if you get to the end of life, and that is where it becomes tricky, is that there's a net time to benefit for all of these medications as well. But they all give the risk of bleeding. So somewhere between entering the palliative phase and dying, there should be a moment to reconsider and stop. And that is a very complex thing to do.
Well, I struggle with this concept. I struggle with I think this is my biggest struggle is antithrombotics, like anticoagulants, DOACs for AFib, for PE. Like, time to benefit makes sense when we're talking about like most preventative medications, including like antihypertensives. But like, if I calculate their CHADS-VASc and there's like a 15% chance of having a major event in the course of a year, there's still a chance in the next 3 days that they may have that major event. I'm not as worried about them dying, but having a major disabling stroke in somebody who's still walking.
They all may get a major bleeding.
Oh, bleeding.
So there's a side effect to these medication, and especially in certain populations at the end of life, such as cancer in the end of life, they have an increased risk of bleeding even. So then where is the balance between this? You obviously in a year time you can get a stroke if you have AFib, but you can also get a major bleed. And we know that at the end of life, bleeding is something that is really detrimental for your quality of life and quality of dying. Bleeding is never a good thing.
Yeah.
I'll just, because I've read some Simon's papers from the Serenity Group, and we're looking at this as well. So, what it aligns is that I think there's also discordance between what patients are worried about and what clinicians are worried about. And so, clinicians are worried about bleeding, patients are worried about having a stroke, and caregivers are having a stroke, and having a stroke and living and being debilitated and dependent. I think is also a big concern. So, I think in discussing the risks and benefits, I think because there's that discordance, it makes it even that much kind of harder where people are starting on opposite extremes. And we have pretty bad prognostic tools for stroke and bleeding in this population. We're presenting this at the annual assembly, but not surprisingly, I mean, you had mentioned 50%, Chad's VAS, but I mean, we're seeing that close to 100% of people have a CHA2DS2-VASc that puts them in the high risk category. They were developed in community dwelling
for people who are approaching the end of life, right?
And people in hospice,
everybody has a CHA2DS2-VASc. That's
everyone's at high risk.
100%.
And everyone's at high, and most of them are at high risk of bleeding as well. I mean, we're not as good at that because some of the tools, some of the variables are harder to get at. So,
how often are people actually being prescribed these meds at the end of life, like in hospice?
I'm not sure about hospice, but in this Serenity Consortium where we did all kinds of work to prepare a clinical trial and a shared decision support tool, there was one particular study who looked at this, and there we found that in the last month of life, so retrospectively, still 80% of patients were using anticoagulations, and the average time before death of stopping it was 14 days. So this is something that is in the last phase of life really, really common.
Yeah. And Serenity, were those European sites?
Yes.
And Jen, I think you have some data from US, a JAGS publication.
Yeah, that's the paper that JJ helped lead, and I don't know if the numbers.
JJ senior author on that one.
Yeah, JJ, what did that paper show?
So that's Emily Short's paper, who's also presenting on our CHA2DS2-VASc and has played stuff at the annual assembly. And so we observed it was 21% in a large hospice population, so over 50,000 hospice patients. Admittedly, most of that was, antiplatelets and really aspirin, is a big player there, the biggest player there. But still, a lot of people are on warfarin and DOACs. And
were the aspirin people for primary prevention like something that most people shouldn't be on, or is it?
That's harder to tell retrospectively, right? I mean, I think indication-wise, we know what some of their underlying diagnoses were, but it's tricky to know exactly what they were being prescribed for. I think anecdotally, and we're also engaged in some qualitative work now. I think we're hearing that, but that sometimes people are on it. Also, people are on, it's a de-escalation from something that they were on before, so that they want to give them something. I see Simon nodding. I think they'd probably see something similar in Europe, that they're on a warfarin or a DOAC, and then they want to take them off of that, and so they'll put them on, but they'll give them still an aspirin for some prevention and also to palliate anxiety as well. That's maybe the primary indication there.
Okay, I'm still stuck because I still struggle with this issue. Warfarin was kind of easier because most people didn't want all the blood draws and monitoring, especially DOACs. It's just a pill. Simon, you're working on a study, right? That's looking at helping clinicians, patients, families think through this.
Yeah, so because this is actually very complicated, and there's no really a true answer, or we don't have the prognostic information, so there's not a good or bad answer. I heard your podcast of last month about uncertainty, and this is all about uncertainty, right? We just don't know. But what we do know is that it is something that should be on the table to discuss. So we're working on a trial in which we are testing a shared decision support tool in which we make patients aware that there's even a choice, and also to show to them that there's not only a benefit of the medication, but that there's also a bleeding risk associated with the medication. We just already, somebody said that usually patients and their families are attached to the benefit and the doctors are worried about the side effects. And the shared decision support tool is to basically support the patient with information about this choice and also about what their role is in this choice process. And it's about educating them on shared decision making as well.
Mm-hmm.
And part of the intervention is also that we teach the medical doctors, the oncologists in this case, about the exact same thing. So we show them these kinds of numbers of patients taking these medications until the last weeks or days of life even. So hoping to spark them to have this discussion about reconsidering this medication much sooner than they would have by just waiting for it.
Mm-hmm.
And there was a lot of research done in this consortium. Also, for instance, one thing that was very hard to establish was, okay, so now, and which doctor is actually the owner of this problem? Because usually the cardiologist will say, no, some kind of palliative care doctor would need to do it. And the GP would say, no, the medical specialist in the hospital would do it. So this is also about who is going to take ownership of this problem. And that's why we specifically targeted one group, cancer patients and oncologists, to teach them and their patients and their caregivers about this reconsidering.
So let me ask you this, Simon. How are you addressing the information? Like, what do we know about the benefits and risks in this population? The benefits, let's say for AFib, the benefits of preventing a stroke in the hospice population versus the risks of bleeding in this hospice population with cancer. Like, for the shared decision making, like, how are you addressing like those two things?
Yeah, so without going into individual prognostication, because there's not any reliable models, and also it introduces all kinds of privacy issues in the trial, but we just give them the information from epidemiological studies. At your age with cancer, what is the risk of you getting a bleed in the next year? And then you see that 1 in 3 or something, that it's really large numbers that has the risk of getting a bleed.
Yeah.
And what is the risk of you actually getting a stroke or a pulmonary embolism? And then you see that risk is lower. And then still you can weigh, is getting a stroke, is it worse, like you said, because it makes you also dependent? But then at least you can have that conversation. And we hope that will inform the patients, maybe not even at the single moment that we introduce this shared decision support tool, but somewhere down the line, if they start deteriorating and really going into hospice, that by that time, everybody will understand, well, this is the time to stop and focus on comfort only.
Because you think most people on hospice should be off medications like DOACs, given what you just said there. Yes. Yeah. Jen?
I would have to agree. Yeah.
JJ, from an epidemiologist perspective?
I think that the data suggests that that's the way to go. So that's, yeah.
Can I ask Simon, by way of follow-up, well, a couple things. One, I heard you say earlier, you did this study of the last month of life, last 30 days of life, and the prevalence of anticoagulants or antithrombotics overall was, did you say 80%?
Yeah, so of those people who use antithrombotic medication, which was, by the way, a general practice population, of those people who used it and died, 80% were still using it 1 month before they died.
That's such a high proportion.
Yeah.
And in hospice, it's 20%. So it's not quite comparable because there are like half of people use hospice before they die in the US. But it does seem, I'm starting to get the sense that maybe this is a bigger issue in Europe than it is in the United States, which is somewhat surprising. Maybe I'm wrong about that.
So it's always very, very interesting to compare systems.
Yeah.
I think we have hospice here as well in the Netherlands and across Europe, but only a very small minority of people go there. Most of the people just die at home under the care of their general practitioner. Mm-hmm. And going to a hospice is a clear moment to have this kind of conversation. So I can imagine that there's already a filter in the beginning of this hospice where already a lot has been deprescribed. Whereas if you're at home, that is not a defined moment per se.
Right. And then the other point I wanted to question is, when you talk about bleeding risk, is it kind of nuisance bleeding or is that major bleeding events?
Any bleeding.
So it could be like a nosebleed, for example.
Could be a nosebleed. And there's people in our consortium. Simon Noble who done studies before. He's a palliative care physician, and he's done studies before that any bleeding is associated with loss of quality of life in palliative care.
Yeah, so it may be,
that's why
it
we
seem like a nuisance, but
is there anything that's truly a nuisance bleed?
Yeah.
Okay, I gotta ask a question. We're running out of time, but we're getting to the place like we have these drugs. Are there frameworks to talk about deprescribing with patients and family members, knowing this is complex? Like, people get attached to it, and this is maybe not even something the system is thinking about as far as deprescribing in certain situations. Jen?
Yeah, so there are, I'll put two out there. I'll put one out there that is called FRAME, and some really, the big hitters in this group, in this field, Lynn McPherson, Jennifer Tjia, and Kara Tannenbaum. FRAME is all about fortifying trust with people when they're talking about this, because they want to know that. So when somebody enters hospice in the U.S., there's a bunch of new docs that come by, and the new docs have to try and figure out how to talk about stopping the cardiovascular drugs that the cardiologist said for 20 years you need to take. So trust is a huge issue. There's R, which is reviewing the willingness or barriers to deprescribing. Then there's trying A, which is aligning recommendations. M is managing the cognitive dissonance. Wait, I had to take this forever, and now you're telling me no. Am I dying? And E is empowering continuation of the conversation. So one framework out there is called FRAME. There's a second one out there that my group put together with Ariadne Labs, and Ariadne, as you know, put together serious illness. And we have called this the goal concordant prescribing approach, because we really think it has to do with the goals of what the patient and the family want. And so we think that it's very similar to FRAME. Really review where the patient's at, with all their meds. They're ready to stop. They're not ready to stop. Are they wedded to certain meds? Review their goals. What are their goals for their life, but also for the meds, and review the meds in terms of what the meds can do. And then, like FRAME, align the med prescribing with what the goals are. And then S is, we really want them to simplify. You review, align, and simplify the meds. But again, it's review, align, and simplify, and rinse and repeat, because things change. And always say, like Simon was saying before, you can't do it all at once.
Yeah.
You can do a little bit, and then you see how it goes. Let people know that there is a choice, and then revisit it as things progress. So goal concordant prescribing, it's in general palliative medicine, or FRAME, look them both up. There are these more general frameworks that are bigger than just the one, that the single drug prescribing aids.
I love both of those, because it also aligns with kind of how we do family meetings, right? We talk about what's going on. We talk about what's important, their goals, and then we make a recommendation that's aligned with their goals. And specifically, like, we actually say the aligning statement. Sounds like X, Y, and Z are most important. Based on that, I think we should do this. Is that kind of how we do goal concurrent prescribing?
This is the intention. Yeah, this is the idea to ground. I'll tell you why we came up with this, to ground the recommendations and where the patient and the family are at, to really let them lead. Because what often happens, or what the fear is, or the stereotype of hospice is, hi, you're on hospice. We need to stop all your meds now.
Yeah.
It's a very negative approach. And what we really emphasize in goal concordant prescribing is this positive approach.
Yeah, you're not saying deprescribing.
No. I hate that word. That's a whole other, let's have a whole other podcast on the word deprescribing and why we need to get rid of it. But anyways.
Do you like Eric's word, debridement?
Debridement is good. Either. I've heard that one before.
You do like that? Enough families like it.
The thing about GCP is that it's all positive. What are your goals? We're aligning with your goals. Less is more. We really try and keep the message positive.
Yeah, so, I love that. Because the amount of times, like, we're caring for people with heart failure and the family members think, hospice means we're going to stop all their heart failure meds. And we're all, no, we may stop some of them that we don't think are aligned with your goals or going to help you. But man, those diuretics are probably important in some patients.
100%. Yeah.
Well, I want to thank all of you for joining us on this podcast. This was wonderful. We're going to have links to all of these studies we talked about, the frame and the goal concurrent prescribing papers as well. But before we end, Alex, maybe we can fare you well to all of our meds that we don't like anymore, to the statins at the end of life.
We'll put them to bed. In a bed by the waterside, I will lay my head, listen to the river, sing sweet songs to rock my soul.
Simon, Jen, JJ, thanks for joining us on the podcast. This was wonderful.
Thank you very much.
Yeah. Thanks for.
And to all of our listeners, thank you for your continued support. We'd also like to do a brief shout out to those listeners who've donated more than $250, including
Kate Mesrich, Jen Hopping, S. Ashad Abid, Michael Bordowski, Harry Hahn, Carol Heyman, Gretchen Schwarzy, Sharon Bragman, Elizabeth Chung, Paul Amatelli, Brian Cassell, Victoria Braun, Susan and John McFadden, Christopher Heck, Emise Simoji, Matt Schuster, Carrie Hagan, Lloyd Woolstadt, Carrie Levy, Mamie Fetzer, Ron Sabar, Stephanie Gabatuller, Patrick Lally, Richard Lewis, Margaret Leung, Cindy Harris in honor of Emily Guillot, April Sear, Anna Nayak, Xinyi Wang, Sudha Chandrasekhar, Michelle Reisner, Asher Edwards, Susan Nelson, Rebecca Goldstein, Rochelle Bernacki, Carol Dietrich, Mark Andrews Wren, Elizabeth Cobbs, Amy Rack, and Meg Walhagen.
Your support keeps the microphones running, so thank you very much.